Okay, we're going to work on Chapter 27 entitled Patient Safety and Quality. So safety can be defined as freedom from psychological and physical injury. According to Maslow's hierarchy of needs, which takes priority? It would be the physical. Nurses play a critical role in teaching patients and their families how to maintain safety in their homes and communities. Nurses also help maintain patient safety in healthcare settings. So what are safety risks in the home environment? Falls, burns, fires, poisonings, either food or medicine poisonings. What are some safety risks that you can think about in the community? Motor vehicle accidents, natural disasters, and bioterrorism. What are safety issues in the healthcare environment? That would be falls, medications. Falls can come from medications, orthostatic hypotension, impaired mobility, vision problems. Those are all issues that can cause falls. So in the facility, we have 3 different termed accidents that you need to know. 1, patient inherent accidents. 2, procedure-related accidents. And 3, equipment-related accidents. When we talk about patient inherent accidents, we're talking about accidents other than falls in which a patient is the primary reason for the accident. One of the most common precipitating factors of patient inherent accidents is a seizure. So it's something that happens within that patient that causes the accident. Procedure-related accidents would be those caused by healthcare providers, like medication errors, infections from improper performance of urinary catheter insertion, anything that would happen as a result of a healthcare provider's procedure. Equipment-related accidents would be the improper amount of IV fluids. These would be anything that would relate to the equipment that we use, maybe an electrical shock or fire. And then I also want to remind you about the safety risks and issues of never events. Remember, we talked a little bit about never events before, and remember that those are events that the Centers for Medicaid and Medicare Services have determined should never happen, and costs associated with these events are not paid. Please reference page 378, box 27-4. Which of these can nurses direct effect? Which of these can nurses directly affect? CAUTIs, CLABSIs, falls, pressure ulcers? So when an actual or potential adverse event occurs, the nurse or healthcare provider involved completes an incident or occurrence report. I need you to know this term. You'll learn it later as well. We'll talk about it again. But an incident or occurrence report, that would be a report of whatever happened as far as the accident goes in the facility. Reporting allows the hospital to identify trends and patterns and areas to improve. Focus should be on the cause of the event instead of on the individual. Every developmental age involves specific risks to safety. Like as a child younger than 5 years of age, they're at greater risk for home accidents that result in severe injury and death. They include poisoning or choking, fire from playing with matches, falls, riding unrestrained in a motor vehicle, drowning, and head trauma from objects. Accident prevention requires health education for parents and the removal of dangers whenever possible. If we're talking about school-age children,
They're at risk for injury at home, at school, and while traveling to and from school. They perform more complicated motor activities and often are uncoordinated. Also in this age group, we worry about stranger danger, sports safety, and safety equipment should all be taught to this age group. We should encourage them to wear helmets when they're bicycling. In our adolescent age group, adolescents are at risk for injury from automobile accidents, suicide, and substance abuse. They engage in what we call risk-taking behaviors like smoking and drinking. And then threats to an adult's safety are frequently associated with lifestyle habits. What we mean by lifestyle habits are like smoking, drinking, hazardous work, etc. Risks for injury for our older patients are directly related to the physiological changes of the aging process, including effects of multiple medications, psychological and cognitive factors, and the effects of acute or chronic disease. Those increase in older adults' risk for falls and other types of accidents. The risk of being seriously injured in a fall does increase with age. So please remember that the increase in age is going to increase their fall risk. Unintentional injuries are the fifth leading cause of death for Americans of all ages. Motor vehicle accidents are the leading cause, followed by poisoning and falls. Vehicle design and equipment such as seat belts, airbags, and laminated windshields, which remain in one piece when impacted, have improved safety for vehicle occupants. Child safety seats and booster seats should be used at all times. And according to the CDC, the risk of motor vehicle accidents is higher among 16 to 19-year-old drivers than any other age group. An older adult is not always able to quickly observe situations in which an accident is likely to occur. A poison is any substance that impairs health or destroys life when ingested, inhaled, or absorbed by the body. Almost any substance is poisonous if too much is taken. Sources in a person's home include drugs, medicines, other solid and liquid substances, and gases and vapors. Poisons often impair the function of every major organ system. A poison control center is the best resource for patients and parents needing information about the treatment of an accidental poisoning. Falls are a major public health problem. Among adults 65 years and older, falls are the leading cause of both fatal and non-fatal injuries. Numerous factors increase the risk for falls, including a history of falls. Being age 65 or older, reduced vision, orthostatic hypotension, lower extremity weakness, gait and balance problems, urinary incontinence, improper use of walking aids, and the effects of various medications all put the person at risk for falls. Falls are also a common problem in the healthcare setting. The leading cause of fire-related death is careless smoking, especially when people smoke in bed at home. Space heaters and appliances also can cause fires. Multi-purpose fire extinguishers need to be near the kitchen and any workshop areas. Advise families to only purchase newer model space heaters that have all of the current safety features. Patients receiving home care should have a home hazard assessment performed. Walk through the home and the patient and discuss how he or she normally conducts daily activities and whether the environment poses problems. Why would you ask a hospitalized patient about their home environment? Well, to assess the patient's safety to be discharged home. You need to assess their educational needs, their equipment needs, or home safety assessment. So let's talk about some areas of the home that we need to address. We need to address their adequacy of lighting, both inside and outside. presence of safety devices like smoke detectors and carbon monoxide detectors, and even fire extinguishers and locks on doors. Furniture that can create barriers, scattered rugs, and other furniture. Knowledge of food storage. We need to make sure that they understand that they must clean fresh fruits and vegetables, and they need to check expiration dates. Assessment of environmental comfort. So we would have to make sure that they had a functional furnace and air conditioning, and check their use of space heaters. They should have the latest space heaters that will turn off if they fall over. And these are some of those nursing diagnoses that I've been talking about that would relate to falls. So maybe you want to hold this slide aside or make some notes so that you will be able to do, when we get to that chapter, you'll be able to think of some nursing diagnoses that are pertaining to accidents. For instance, the risk for falls. What makes these patients risk for falls? Well, older than 75, or maybe use of a walker, or maybe they're confused. Also, look at the one for risk for injury. We could choose that for a patient that's confused, trying to remove their urinary catheter, for instance. That might be a good indication they're at risk for injury. When selecting a nursing diagnosis, which is covered in Chapter 17, you will use North American Nursing Diagnosis Association, for short NANDA, N-A-N-D-A. These are a list of approved diagnoses. And remember that page 228, you can reference that as well. That has the nursing diagnosis list on it. When would you use the nursing diagnosis for some of these patients? Just start to think about that. Like the one that we just talked about, risk for injury, our confused patient that's trying to remove his urinary catheter and even maybe his oxygen cannula. That's definitely a risk for injury. The injury hasn't happened yet, but there is a risk for it if they're having this kind of behavior. And what would you do as a nurse in this situation? Well, we could prevent the patient from incurring any harm by using different methods, like maybe a sitter in the room, family member in the room, or maybe we could put the patient near the nurse's station. If the patient is able to sit, sitting patient in the chair near the nurse's station might work. Or finally, and after all else fails, getting an order for restraints and applying restraints. We'll talk about restraints in another chapter. Patients with actual or potential risk to safety require a nursing care plan with interventions that prevent and minimize threats to their safety. Make sure that goals and outcomes for each nursing diagnosis are measurable and realistic. Goals for risk for falls. Patient will remain free from falls this shift, or patient will be able to explain methods to prevent falls at home prior to discharge. Why is it important to involve the patient in planning care? For one, we know that if we incorporate them in their care plan, they're going to be more motivated to finish the goals. And because, remember, our patient-centered care, we want to involve them in their planning care. Prioritize a patient's nursing diagnosis and interventions to provide safe and efficient care. Plan individualized interventions on the basis of the severity of risk factors and the patient's developmental stage or level of health, lifestyle, and cultural needs. For example, what safety hazards are highest in priority? Well, risk for falls or anxiety, which one? If we think about Maslow's, it's definitely risk for falls. Collaboration with the patient, the family, and other disciplines such as social work and occupational and physical therapy becomes an important part of the patient's care plan. Communication to other staff is essential. Permanent dry erase boards in patient rooms can have information such as activity allowed and level assistance needed. Here is a box, or a table rather, 27-1, that I want you to reference for the teaching of children and parents. How do we baby-proof a home, for example? Don't forget the child safety seat is less than 80 pounds or under 8 years of age in a car seat. In cars with a passenger airbag, children under 12 need to be in the back seat. Please reference pages 385 to 386. Adults, what kind of lifestyle modifications do we need? Maybe nutritional modifications, exercise, maybe substance abuse, quitting smoking, stress management. Older adults, neighborhood resources maybe, Meals on Wheels, modes of transportation. Safe driving tips even. Driving shorter distance or only in daylight can obtain prescription maybe for formal driving assessment. They are done. For an example, Brooks Rehab will do an assessment of the aged person to find out if they're safe driving. We can also reduce the risk of burns by reducing the temperature of the hot water heater. That could prevent accidents in our older population. Nursing interventions for older patients reduce the patient's risk for falls and other accidents and compensate for the physiological changes of aging. So how would we reduce falls in the home for our patients? Maybe remove obstacles, remove clutter, remove cords, or throw rugs that might cause them to fall. We could also install handrails and grab bars to prevent some accidents. We could ensure adequate lighting so they can see their way around. Maybe we want to repair loose or uneven floor and even stairway surfaces. When going out into community settings, patients should be encouraged to take their assistive devices along on all occasions and properly use them. Please reference box 27-8, page 387. This would be the focus on older adults. So it takes a look at physiological changes of aging and their effect on patient safety. Here are a group of bands that you might see in the healthcare facilities. Please make sure that you remember these colors with what they're associated with. So what happened in 2008 was that the American Hospital Association came together and decided that hospitals should use standardized wristband colors. For instance, the red for the patient allergies, yellow for fall risk, and purple for do not resuscitate. Standardized color coding is a movement that needs to continue throughout the country. Nurses need to identify patients at risk and communicate this with other healthcare providers through these patient armbands. When we talk about this slide, I want to give you another reference, Skill 27-1 on page 395. This would be testable material, and you'll be responsible for knowing these skills. Despite the need for comprehensive fall prevention programs, many interventions are simple and involve manipulation of the environment by the nurse to meet patient needs. For instance, keep the bedside environment free from clutter. Explain how to use the call light to your patients. When a patient is assessed as a fall risk, most hospitals have fall prevention protocols instituted. Yellow wristbands mean risk for falls. You can also find skid-proof footwear. Oftentimes that will be color-coded as well. Patient-centered care is important, with nurses making patients and families their partners in recognizing fall risk and taking prevention action. When patients use assistive aids, it is important to routinely check the condition of rubber tips and the integrity of the aid. Patients are at risk for falls during transfer tasks and receiving while seated in a wheelchair. That's reaching while seated in a wheelchair. The Food and Drug Administration, FDA, recommends that all bed rails be used with caution, especially with older adults and people with altered cognition, physical limitations, and certain medical conditions. Many deaths from entrapment and falls have occurred. The top two side rails are used for patient positioning. Use of one of the bottom side rails is necessary in certain patient circumstances. A patient needs to have a route to exit a bed safely and move freely within the bed. Additional safety measures include the use of a low bed with a non-skid mat placed alongside the bed on the floor. Note that when all four side rails are raised, it's considered a form of physical restraint, which requires an order from a primary care provider. So let's not forget this, that if you have all four side rails up on your patient's bed, that would be a form of physical restraint. And we are to always have an order from the primary care provider if we're going to use restraints. As with a physical restraint, it is critical to weigh the benefits of risk and the use of side rails. Okay, so on this page, this is a skill that I want you to reference as well. Page 400, 399, and 400, skill 27-2. Restraints are a temporary way to keep patients safe. Physical restraints immobilize or reduce the ability of a patient to freely move his or her extremities, body, or head. Chemical restraints are medications such as anxiolytics and sedatives used to manage a patient's behavior and are not a standard treatment or dosage for a patient's condition. Serious complications include pressure ulcers, pneumonia, constipation, incontinence of death. So don't forget that using restraints, we have these very serious complications, the pressure ulcers, pneumonia, constipation, incontinence, and death, because they can't move around. Use physical restraints only, I want to stress only, as a last resort, when patient's behavior places them or others at risk for injury. Also, the Joint Commission has set standards to use when applying restraints, but they also state that alternatives must be tried first, and this has to be documented. The optimal goal for all patients is a restraint-free environment. Always consider and implement alternatives to restraints first. What are alternatives to restraints? Well, distraction, maybe folding some laundry, family involvement, frequent reorientation of our patients, maybe some social interaction, sitters, or we could always have the patient sit next to the nurse's station. Current nursing home laws prohibit the unnecessary use of restraints, except in emergencies. Nursing homes cannot use restraint without a resident's consent. You'll find some facilities that are restraint-free. For legal purposes, note agency-specific policy and procedures regarding appropriate use and monitoring of restraints. A physician's order is required and must be based on a face-to-face assessment of the patient. They cannot, okay, I repeat, cannot be ordered PRN. It used to be the case where we could order restraints PRN, but no longer. Type of restraint, location, duration, and reason for use need to be specified. Restraints can be placed prior to an order in an emergency. You must conduct ongoing assessment of patients who are restrained. Restraint must meet one of the following objectives. I'm going to name these 4 objectives. And just remember, restraints must meet one of the following. Number 1, reduce the risk of patient injury from falls. Number 2, prevent interruption of therapy, such as traction, IV infusions, nasogastric tube feeding, or Foley catheterization. Number 3, prevent patients who are confused or combative from removing life support equipment. Number 4, reduce the risk of injury to others by the patient. Now, we talked about alternative ways to help our patients. There are what's called alternative restraints. Those can include electronic devices, the Posey bed that you see in the picture. The Posey Stay Safe bed, in fact, is what that's called. A soft-sided, self-contained enclosed bed is much less restrictive than chemical or physical restraints. But I will tell you that if you do have a patient that is restrained in one of these beds, you need to let the family know before they see the patient in this capacity. It can scare them. Healthcare facilities implement several actions to prevent fires and to ensure adequate preparation if one occurs. Smoking-related fires continue to pose a significant risk owing to unauthorized smoking in the bed or bathroom in healthcare facilities. Oxygen is flammable and should not be used near an open fire. Electrical equipment. 3-pronged. The third prong carries any stray electrical current back to the ground, so it should be a 3-pronged plug. Remove and tag equipment not working properly. Also, make sure you understand that anyone bringing in electrical equipment from home must have it checked per policy at the hospital or the facility prior to using it. Nurses need to know where the fire extinguishers and gas shutoff valves are located, how to activate a fire alarm, and the facility's evacuation plan. This is usually covered under orientation. If a fire occurs in a healthcare facility agency, protect patients from immediate injury. Report the exact location of the fire, contain it, and extinguish it if possible. All personnel evacuate patients when appropriate. The mnemonic RACE, or RACE, explains priorities during a fire. What would you do first if you entered your patient's room and saw a fire? Rescue the patient or remove them from harm's way. Also, PASS, or PASS, explains how to use the fire extinguishers. You pull, aim, squeeze, and sweep. Box 27-14, page 394, will give tips for protecting patients during a seizure. A seizure is an abnormal, sudden, excessive charge of electrical activity within the brain. A generalized tonic-clonic seizure, grand mal seizure it's called, is characterized by stiffening of the muscles of the arms and legs, followed by loss of consciousness, then jerking of the extremities. What would you do if you were ambulating a patient or she is sitting in a chair and starts to have a seizure? The answer is you would lower them to the floor safely. Usually last about 2 minutes. Seizures typically last 2 minutes. They'll go through a post-ictal phase, which just simply means after the seizure, and we should allow that patient to sleep. What do you think you should document after the seizure? Well, you want to make sure you document the duration of the seizure. How long did it last? You want to document the progression of movements during the seizure. Always document any incontinence. And you want to document the behavior following the seizure, as well as any loss of consciousness. Status epilepticus is a seizure lasting longer than 5 minutes or a second seizure before the patient recovers. What are our seizure precautions? You really need to know. We want to have available suction equipment and oxygen tubing at the bedside, and we want to pad the side rails for patient safety. In the event of a disaster, the emergency response plan is immediately activated. Find out what that disaster, the emergency response plan is in each facility that you work in. Okay, you'll be asked questions about delegation throughout the nursing program. I want to make sure that you know these. The 5 rights of delegation are right task, right circumstances, right person, right directions or communication, right supervision and evaluation. Application and routine checking of a restraint can be delegated to nursing assistant personnel if they have received appropriate training. And I want to make sure that you understand with the restraints that you're the one that has to be responsible for checking underneath those restraints. Those restraints must be removed every 2 hours so that you can assess the skin and the range of motion of whatever extremity is restrained. So just make sure that you go every 2 hours to actually remove the restraints and do some range of motion and check the skin integrity. And then when a patient is restrained, they should have flow sheets where you are checking off to make sure that you have seen them every 15 minutes. You have laid eyes on them. And always check your policy in your facility. Okay, so back to delegation. RNs, they must assess, teach, and evaluate. And the other rule I want you to know about delegation is the patient must be stable in order to delegate any care whatsoever, whether that be vital signs or anything else. If that patient is not stable, the RN must do it. So you want a patient that's stable before you delegate. You cannot delegate any assessments. You cannot delegate teaching, and you cannot delegate evaluation as an RN. Okay, let's look at evaluation. Always patient-centered care, and that involves a thorough evaluation of the patient's perspective related to safety and whether his or her expectations have been met. So, evaluation includes monitoring the actual care delivered by healthcare team on the basis of the expected outcomes. For each nursing diagnosis, measure whether the outcomes of care have been met. When a patient outcomes are not met, ask the following questions. What factors led to your fall or injury? Help me understand what makes you feel unsafe in your environment. What questions do you have about safety? Do you need help locating community resources to help make your home safer? What changes have you recently experienced that you believe contribute to your risk for falling or lack of safety? Continually reassess a patient's and family's need for additional support services, such as home care, physical therapy, counseling, and further teaching. Overall, your expected outcomes include a safe physical environment and a patient whose expectations have been met, who is knowledgeable about safety factors and precautions, and who is free of injury. While caring for a child, you identify that additional safety teaching is needed when a young and inexperienced mother states that it is number 2, a 3-year-old can safely sit in the front seat of the car. What should the nurse do to best prevent a patient from falling? It is number 3. Number 1, the patient may not need a cane. Number 2, although this should be done, it's not the best prevention of the options presented. And number 3, this widens the patient's base of support, which improves balance and decreases the risk for a fall. Number 4, although this should be done, it is not the best intervention of the options presented. A newly admitted patient was found wandering the hallways for the past 2 nights. The most appropriate nursing interventions to prevent a fall for this patient would include, it is number 2, use an electronic bed monitoring device. For wandering patients, an electronic monitoring device can be used to notify the nurse when the patient is mobile.
A nurse floats to a busy surgical unit and administers a wrong medication to a patient. This error can be classified as number 3, a procedure-related accident. When an error occurs due to the actions of a healthcare provider, it is considered a procedure-related accident.